sonography, echocardiography of blood pressure. Echocardiography is the electrocardiography. The ST segment does elevated or does not elevated. In practice, the normal arch have a content of the enzymes, myoglobin and phosphokinase and other CK, RNB. If the infarction present in the arch, so they automatically release of the troponin in the bloodstream. This is showing of the normal range value of the enzymes. What's the treatment of the acute myocardial infarction? The other one is the electrocardiography. Normal left ventricle area is contracted when the infarction is produced, so the contraction is the loss. Akinesia are producing in the muscles of mental what's the treatment of the myocardial infarction? The treatment, aspirin is the normal dose of 160 or 325 milligram. When we are given the patient to the myocardial infarction, 75 milligram daily wise treatment. This is the package of the blocking of the cyclooxygenase and phosphokinase inhibitors, the platelet aggregation inhibitor. Supplementary oxygen. We should we give the for the pulmonary edema, or we should give the for the dyspnea. We should we give the saturated oxygen for the nitrates. Nitrates is the good painkiller when the patient have a hypertension, when the patient have a severe pain. We should give the nitroglycerin sublingual. The dose of the nitroglycerin is the 2.6 maybe. The pain control. How the control of the pain. The strong analgesic morphine sulfate. Morphine sulfate is the dose of the 4.8 up to Heparin is the low molecular weight of the inhaled thrombotic agent. Fibrinolytic is also is the glycoprotein 2B and 3A antagonist. Next. The acute myocardial infarction, other treatment is percutaneous pulmonary intervention. The surgical revascularization also is should be. The prevention, angiotensin converting enzyme inhibitors are the ARB, angiotensin receptors blockers, smoking cessations. These are the plaque formation on the wood on the vessels walls. Also is the we are saying the thrombus. Totally is the occlusion of the coronary arteries. Thank you for your attention.
This is the Dr. Janan's first presentation. It was a nice presentation. He has been very brief. But just, Dr. Janan, tell me when you are on duty in the cardiac care unit, you said that echocardiography, acute myocardial, how many cases you come across when you diagnose acute myocardial infarction? And you do echo for diagnostic purposes?
When I on the duty, so the patient is came, so I cannot tell the echocardiography.
The thing is, what is the diagnostic criteria for acute myocardial infarction? Just listen to me. You said that how to diagnose acute myocardial infarction. So there are three important diagnostic criteria where we have to follow the WHO criteria, right? So it is the symptoms, then the biomarkers, ECG. So you should have at least 2 out of the 3, which will take your patient to a diagnosis either the patient is in acute myocardial infarction or not, right? So these 3 important factors are the diagnostic criteria. Symptoms, which you have elaborated very clearly, very nice. Then ECG changes, right? And then the third is biomarkers. If sometimes the patient does not have a typical type of symptoms which is suggestive of myocardial ischemia, acute myocardial ischemia, but the biomarkers are there or the ECG changes are there. Sometimes the biomarkers are borderline. It's not twofold or more than that. So again you are confused, is this a patient of acute MI or not? Then the ECG and symptoms will support you, right? Sometimes the ECG does not fit in the criteria to give you an evidence that there is a clear acute MI. Now you have to give a thrombolytic or not, or to give treatment for acute MI or not. Then the symptoms and biomarkers support, right? So echocardiography in acute MI, we don't use that procedure as a diagnostic criteria for acute MI. That is when you suspect a patient has come to you that he has got a change in the inferior leads or in the anterior leads. Clinically is all right, so you do echo to see any segmental wall motion abnormality. Is there any segmental wall motion abnormality? Yes. No. So that is for something. Then you can use echo for exercise, ETT or exercise echo, right? For that. For acute myocardial infarction diagnosis, you don't need echocardiography. That can be one of the procedures. Later on, you can do it for special purposes when you are going to do a prognostic certification or further workup or planning for that patient, right? So then you can do it. But these 3 things for you people who are working in cardiac care unit or in the emergency department or whatever. So you have to follow these 3 things in your diagnostic. Symptoms, biomarkers, and ECGs, right? It was a nice presentation. It was your first presentation. You definitely improve it. जी आप लोग हाउस अफसर कुछ पूछना चाहिए डॉक्टर जानान से, क्योंकि आप लोग अभी एमओस के साथ ड्यूटी करते हो तो कोई चीज़ आपको प्रॉब्लम हो डायग्नोसिस में, ये लेकिन आप बड़ी इंफॉर्मेटिव चीज़ें थी ना कि किस तरह सीखी आप करते हैं और डॉक्टर जानान ने बाकायदा डायग्राम बनाए थे कि एक्यूट एमआई किस तरह होता है, किस तरह क्लैप होता है, उसमें थ्रोम्बोसिस कैसे बनता है। फिर इसने ये भी कहा कि एक्यूट सडन ऑक्लूजन और ग्रेजुअल ऑक्लूजन, ठीक है, पहले अनस्टेबल होता है, टोटल ऑक्लूजन नहीं होती है, देन विद द पैसेज ऑफ टाइम देयर इज अ टोटल ऑक्लूजन एंड देन दैट वुड इज एक्यूट। और या उससे पहले अनस्टेबल होता है या एकदम टोटल ऑक्लूजन होती है एक्यूट एमआई। तो इट डिपेंड्स ऑन द ड्यूरेशन ऑफ द ऑक्लूजन ऑफ द वेसल की कितना एक्यूट होता है या कितना प्रोलॉन्ग हो सकता है, ठीक है। फिर इसने ट्रीटमेंट में जो बताइए ना कि ऐसा पेशेंट आता है तो एकदम एक एस्पिरिन तो एक या 2 गोली एक साथ दे, फिर दूसरे ऑप्शन दिए कि आप ऑक्सीजन दो, नाइट्रेट्स दो, ठीक है। लेकिन द मेन स्टेज के आप जब डायग्नोज करेंगे ड्यूरेशन ये सब टू वर्क अप दैट फॉर थ्रोम्बोलिटिक इन द शॉर्टेस्ट पॉसिबल, क्योंकि उसी में आप जो है मायोकार्डियल नेक्रोसिस बचा सकते हैं, आप थ्रोम्बोलाइसिस कर सकते हैं ताकि फ्लो जो है वो जियोपोटाइज मायोकार्डियल को कंटिन्यू रहे और नेक्रोसिस से बचा रहे, ठीक है। और बाकी कुछ एडिशनल चीज़ें इसलिए दी है कि 2B3 इनहिबिटर्स जो है ये एक्यूट एमआई में मतलब इस तरह